Hi, welcome. This is a study guide focusing on what you need to know about coronary artery disease. I hope it helps you with your exams and NCLEX. The very famous question: what's the common cause of heart attack, angina, coronary artery disease, acute coronary artery syndrome? That's atherosclerosis, plaque buildup. You will see this question at least once in your lifetime as a nurse or as a student. The common cause of variant angina. Remember, variant angina is the vasospasm of a part of the coronary artery. So the most common causes of variant angina or premenstrual angina includes use of stimulants like caffeine, coffee, energy drinks, cocaine overdose. A very big problem among young adults and teenagers. What are the types of coronary artery disease? We have silent angina. Patient presents with no symptoms, but EKG shows ST elevation or Q wave. Variant angina, we just talked about it. Vasospasm in the coronary artery. Stable angina, very famous. It's predictable when it's going to happen. Patient gets relief when they rest or take sublingual nitro. Acute coronary syndrome, which includes three things: unstable angina, non-STEMI, and STEMI. So, types of coronary artery disease, we have three of them are part of the acute coronary syndrome. That's the unstable angina, non-STEMI, and STEMI. And three are not part of the acute coronary syndrome, which includes silent angina, variant, and stable angina. Let's talk about types of acute coronary syndrome. This is very serious. If the patient falls under this category, it means the occlusion is huge enough that even with nitro, it cannot facilitate continuous blood flow. So, acute coronary syndrome, we have unstable angina. Plaque is in the artery, in the coronary artery, and it has ruptured at this point. But the platelets are going into the on top of the plaque and building up, sticking around, clamping up, and causing more occlusion. But in unstable angina, the occlusion is not significant enough to cause ischemia and cell death. It's like the heart muscles affected will be yelling, "Hey, something is wrong. We are only getting less than 50% of the oxygen and nutrition. Do something." So they're still not ischemic and they're not dying yet. Because the muscles are still getting some oxygen, there's no ischemia. Therefore, you will not see biomarkers like troponin, myoglobin, CKMB present in the labs. And definitely, you will not see ST elevation since there is no cell death and necrosis. Non-STEMI, the plaque has grown large enough and now it's occluding up to more than 75% of the artery. There is ischemia happening at this point. The cardiac cells are affected, and those that are affected are getting ischemic will send biomarkers to signify ischemia. So, the first biomarker that you will see elevated is myoglobin. Even though it's the first biomarker to be elevated, it's not very specific because it's even other cells like skeletal muscles can produce myoglobin. The golden standard biomarker that we are looking for in a myocardial infarction is the troponin I and troponin T, or in short, troponins. When we see elevated troponins, then we know for sure there is cardiac cell ischemia. Other biomarkers is CKMB, also is non-specific. So I said the first one to get elevated, the answer is myoglobin. But the golden standard is troponin. Because we do not have cell death just yet in non-STEMI, we will not see ST elevation in the EKG, but we might see ST depression, which signify ischemia. STEMI, this is like the end-stage renal failure version of the acute coronary syndrome, if you get the joke. In STEMI or ST elevation myocardial infarction, just like the name says, we have cell death, or if you want to sound smart, we have cell infarction. Some cells will be ischemic, and those that are ischemic will keep producing and releasing the biomarkers like troponins, and others that are dead will not be able to conduct electrical activity as usual, and so the EKG will show ST elevation. So, ST depression in non-STEMI and ST elevation in STEMI. How do we treat and manage coronary artery disease? We have premenstrual and variant angina. give or teach the patient to take calcium channel blockers like verapamil, diltiazem, nifedipine, or take nitroglycerin to vasodilate the artery. Also teach them about the side effects such as hypotension, orthostatic hypotension, and some patients will report leg swell or bilateral edema on the feet when they take calcium channel blockers because of that vasodilation. Stable angina. Teach your patient about very rigorous activities that may trigger the pain, and when the pain comes, tell them to stop and rest. Take sublingual nitro, put it under the tongue, do not chew or do not swallow. Let it melt and do its job. Wait 5 minutes. If the pain does not go away, call 911 and take the second pill. They can take up to maximum of 3 pills 5 minutes apart. Then acute coronary syndrome. We have unstable angina, non-STEMI, and STEMI. At this point, the patient has tried nitro and rested and pain still present. They have called 911 and so now they are here in the hospital. During acute phase of acute coronary syndrome, as you try to stabilize the patient before they head over for cath lab or for percutaneous coronary intervention, give aspirin. It's an antiplatelet which will prevent platelets from sticking together and worsening the occlusion. They can also be given nitroglycerin if the patient had not taken it on their way to the hospital. Helps to vasodilate the artery and veins, to reducing the preload and afterload, and of course, it reduces the workload of the heart as well as decreasing the oxygen demand. We give morphine IV if patient is still in pain after the nitro. Morphine also helps reduce preload through vasodilation and decreases anxiety. So in the answer choices, if they're asking what you're going to do first, then you do not choose giving nitro before you give aspirin. The patient is in a hospital setting. And then just know that we give morphine if nitro hasn't done its job. We don't give morphine before we give nitro. So morphine as well, because it causes vasodilation and decreased anxiety in the patient because of the pain and all that is going on. It also helps to reduce workload of the heart and as well oxygen demand. As you do all this, someone else or another team member should be starting a good IV, taking EKG, someone drawing labs for cardiac biomarkers. Remember, the golden standard treatment for acute coronary syndrome is cath lab or percutaneous coronary intervention, PCI. So door to balloon time is 90 minutes. Time is muscle. So have in the back of your mind that you have to stabilize the patient, draw labs. All you need to do all these things, but know that in the back of your mind that cath lab is the main goal. We have to get them to the cath lab within 90 minutes or less. The sooner the better. Post-intervention, if the patient got a stent placement, they will be on a dual antiplatelet therapy. Dual means two. That means either an aspirin plus clopidogrel, or we call it Plavix. So those dual antiplatelet therapy, or just aspirin by itself, to prevent platelets from clumping on top of the stent and reoccluding the artery. They will also be on a beta blocker like metoprolol to prevent heart remodeling and contain blood pressure. ACE inhibitors like lisinopril to manage hypertension. Statins like atorvastatin, which help lower cholesterol and prevent plaque buildup in the artery. Over the years, if the patient does not keep up with the medication and lifestyle, they may need coronary artery bypass graft or CABG. Or if you get a patient who shows up and has complete occlusion, especially of the left coronary artery, which supplies most of the heart muscle, they might get a CABG as soon as possible. And for all of them, of course, teach patients about risk factors like cessation of smoking, healthy diet, the DASH diet, regular exercise, weight management, stress reduction, and diabetes. All of this can lead to injury within the walls of the artery, and this makes the plaques to build up around there, and of course, eventually the platelets and the occlusion. If you are a visual learner like me, this is what it looks like. Image 1 shows the coronary artery occlusion with huge plaque and platelet clumping together on top of the plaque, cutting off circulation. Image 2, the stent placed along the area of the occlusion to prevent reocclusion of that part of the artery. Image 3, that's the balloon angioplasty, where the balloon is inflated at the area of occlusion and opens up the lumen of the artery. And of course, image 4 shows anastomosis or bypass of the area of occlusion so that circulation can continue to reach the distal areas of the artery. So, will your patient require antiplatelet therapy post-stent placement and CABG? Yes and yes. As long as the patient has anything foreign along the pathway of circulation, for instance, a stent, graft, valve placement, they have to be in some sort of blood thinners. So, for post-stent placement, they can be started on a dual antiplatelet therapy, like I said, which includes Plavix and aspirin for about 6 to 12 months, just because the places are highly likely to clamp or stick on the stent during this time. After the 12 months, they can just stay on aspirin alone. As long as they have the stent, they have to take aspirin, or until it's contraindicated to take the aspirin. For example, patients who have a brain bleed or a stroke, the doctor may say stop taking the aspirin. For CABG as well, they also stay on aspirin indefinitely. So how will you know your patient is presenting with a coronary artery disease and not any other thing? So subjective symptoms is what in the patient's own words: chest pain, pressure that feels like an elephant lying on my chest. It might be radiating to the jawline, left side, shoulder, left arm, shortness of breath, fatigue, dizziness, lightheaded. Some may have nausea and vomiting as well. And then objective science, of course, is whatever the nurse is seeing or the doctor, EKG changes, lab, cardiac biomarkers present. We take them to cath lab and we found out there's an occlusion. Vital signs will tell us. And also remember, the test can also ask you about atypical signs and symptoms that we see in some patient populations, like women, older adults, people with diabetes. These populations may have atypical signs, not the regular ones that we've talked about of chest pain, radiating, and all that good stuff. They may, especially women, they may come and say they have some acidity or epigastric pain. They have some back pain that don't go away. They're fatigued. Some will have this impending doom feeling, and some may feel nothing, literally silent angina, like older adults and patients with diabetes, because patients with diabetes, some of them have neuropathy, and because of that, they do not feel pain. So you have to be watchful. Okay, we learned a lot about this point. Now let's talk about our role in this as a nurses. What are the nursing responsibilities? NCLEX will focus on nursing assessment, interventions, and patient education. Assessment, remember, like I said, we are monitoring vital signs. What's the oxygen saturation? If it's lower than 90% or the patient looks like they're in distress, of course, we're going to give them oxygen. Continuous EKG, monitoring of ST segment changes and any arrhythmias, assessing patient pain using the pain scale, asking them about the characteristics of their pain. Is it just an epigastric pain? Is it radiating? Is it a chest pressure? Is there jaw pain involved? Obtain blood samples for cardiac enzymes like troponin, CKMB, lipid panel, and other values, lab values. Interventions, we're talking about prioritizing acute chest pain management with rest and nitro. Remember the acute coronary syndrome. The acute phase meds, we give oxygen only if the oxygen saturation is less than 90% or if the patient is in respiratory distress. We give aspirin, nitro and we give nitro if they have not gotten one already, and we give morphine if nitro did not provide relief. Administering all medications as ordered and monitoring the effectiveness and side effects. Maintain calm, stress-free environment for these patients because that also helps with reducing myocardial oxygen demand. Prepare your patient for cath lab. Get their allergies, witness consent for the procedure. Patient education. Educate patients on the modifiable risk factors like their diet, their exercise, smoking, stress. Teach the proper usage and storage of medications, for example, nitroglycerin. Crucially, instruct the patient to call emergency services 911 if pain is not relieved after 5 minutes of the first dose of nitro. Okay. Explain the importance of medication adherence and follow-up appointments. Provide clear discharge instructions for the patient's lifestyle modifications and when to seek medical help. Thank you for supporting my content. I'll keep doing more videos to help you prepare efficiently for your exams and NCLEX. Bye for now and see you on the next one.